can see my face as well now.
Yes, sir.
Okay. So let's start the talk today. I will be talking about the brachytherapy treatment planning and a little bit about the commissioning and QA of the applicators. This is my disclosure slide. I don't have any financial benefit delivering this lecture and topic, so no conflict of interest. So first part of my presentation or today's talk is about the commissioning and QA of the applicators. So there are a lot of things that when you initiate the services, brachytherapy services, then this is a requirement that we should go through all these entities, like the inventory and visual inspection of the applicators, functional test of the applicators, imaging tests, auto radiographs, and coupling of transfer guide tube with the applicators, because there are different types of applicators and different types of transfer guide tubes, at least with the variant. So, and there are different sizes as well. So we should know that which transfer guide tube should be used with which applicators. Similarly, there is treatment planning parameters associated with the applicators. So it is advised that we should place a sheet of every applicator in the treatment planning system so that we can use this sheet while doing the planning. And we'll be talking about this in the following slides. And there is a option that you can use the solid applicators out of the library templates. So we will touch a little bit about this as well. The next one is the delivery verification of applicator plans via auto radiography. Will be touched this as well. Dosimetry test means that you can like determine the HUs of the applicators, different parts of the applicators, and physical dimension of the applicator. You can verify this with the dosimetry test, especially the HUs. Training of staff, of course, is very important. Development of an annual QA program for the applicators. So each applicator should have the QA program. So, and we'll see a little bit about this as well in the following slides. And in the last example of commissioning of ring applicator, this is we have published a paper about this as well, and we will touch this as well in detail a little bit. So after commissioning of the applicators, so there is a task group report 56, which talks about the different tests, about the applicators, about the source, calibration of the source, source strength, source inventory, source preparation, and so on. Out of this, there are 2 tests which are associated with the applicators. And you can see in the red highlighted rectangle, it says about the applicator integrity, evaluate dummy ribbon geometry, dosimetric evaluation of applicators, orthogonal radiographs of applicators, major applicator dimensions, and so on and so forth. So there are tests as well which are associated with the applicators. So we can go through this report, and we can like with the reference of this report, we can have our own QA program for the applicators. So first part is the inventory and visual inspection. This is very basic part that everybody should create inventory and log of the applicators, which should include the model, serial numbers, and quarterly QA. Similarly, reference documents from the manufacturer. This is very important document, and one should go through the document because there are many different points and different important areas we should look into that. There's a technical diagram of the applicator geometry. We will touch this as well in the following slides. List of applicator components, sterilization instruction. It is very important as well that every applicator has their own requirement of the sterilization. So because there are plastic parts, there are metallic parts. So one should know which part should be sterilized with what techniques. Similarly, there is a applicator verification part where you can see the correct models, correct components of the applicators, and you can create the log for each check, which you may be conducting quarterly or annually. Functional test. Let me switch. Excuse me. Okay, so function tests include the assembly of the test. So assembly of the applicator, which include the applicator. How should we assemble the applicators? Verify each mode of assembly. Check the robustness and functionality of the applicators. Similarly, with every applicator, there is a guide that which transfer guide tube should be connected with this applicator. So we should connect the applicator, and then we should measure the length, overall length of the from the applicator to the end of the transfer guide tube, which is in case of variant, which should be 1300 centimeter. So that is one part that we should verify on and off. Another test could be the channel obstruction by running the dummy wire. Before every treatment, there is a protocol, variant protocol, that dummy goes into the applicator and check for the obstruction and any hindrance into the channel. So that is one part, but this is the one which is like system conducts before every treatment. But other than that, you can make this as a quarterly QA part. You can make this as a part of quarterly QA. The another part is the delivery test. So you can deliver the dummy plans and with the source wires before the actual treatment delivery, and that can be again a part of annual QA or quarterly QA. Okay, so imaging test. So you can do this either with the individual parts or as a collective assemble, as a collective part by gathering all the components together. So you can have the radiograph either with the simulator or with the CT or with the LINAC. If you have the CBCT or planar imager, you can have this with this as well. So that will give us the structural defects. If there is any structural defects, that will be visible when we do this imaging test. There's a part which you can do with the CT. So to measure the dimensions of the different parts of the applicators and HUs, Hounsfield units. Similarly, there is an imaging test. It is very important test, out of which you can put the X-ray markers as well, so that you can see the physical tip of the applicators, with the center of the first dwell position. So that is your reference with which you will be doing the planning, and we will go through this as well when we'll be going with the planning part. So you can see here, can you see my mouse? Oneza, can you see my mouse?
Yes, sir, we can see your mouse.
Okay, so here you can see the physical tip of the applicator, and there is a first source position. So you can have this distance, and you can have the distance of lumen as well. So physical tip to the lumen, you can measure this distance as well. So these are the things that you should be using with the planning part, and we'll be showing this while we'll be doing the planning. So that is the part which we can cover in this imaging test. Here it is more prominent. You can see, especially with the ring applicator, you can see. So there is a dead space, and there is this very special thing, that snacking. You can see the snacking as well. I'll be talking this in the following slides. So dead space you can measure very easily here, and the distance from the physical tip to the first source, center of the first source position. Here is one example that we have made this for every applicator. This is for the flexible geometry applicator variant provided, variant made. And you can see all the components are listed here with their product number, description of the item or the components, what are the quantities of each of these components, what is the material, so that we can use this information to see which technique should be used for the sterilization. So you can see it can be reusable, and it is autoclave sterilization is required for this components, for all these components. Here you can see the probe thickness, which is the dead space. So you can see it is for the colpost head, it is 0.5 millimeter, and for the intrauterine tube, it is 0.5 millimeter. And we measured this and found this to be the 0.45, because it's a very small distance. So you can see the difference is large actually, which is 10%. But in fact, it is very small difference. It's 0.05 millimeter. So that is, I mean, it's fine actually. Similarly, we have measured the distance from tip to the center of the first source position, the nominal or the distance which is written in the manual of the applicator. It is 4 millimeter, and we measured this 3.9 millimeter. So again, it is 3% difference. So in this example, we can see that we can have this sheet for all applicators, for all available applicators, and we can place this data into the treatment planning area so that we can use this information while we do the planning. So this is only the example. This is a vendor provided information which we should be used for the nominal distances, and you can see here the different distances are available here. And with this distances, you can put this as a nominal distances, which is provided by the manufacturer. And against these distances, you can measure your own distances. This is the NCCR commissioning worksheet, which shows the same things. And we are almost following this NCCR guideline for making our own sheets, actually, Excel sheets. These are the parameter sheets to be displayed in the planning area. As I was talking about, that we should use these nominal lengths, dead spaces, offset data for each applicator, for each component as well. And because most of the errors in the HDR is the inaccurate programming of the channel lengths, which can lead to the geometrical miss. So these distances are very important, and everyone should use these distances while doing the planning. There is also an advice that we should measure the channel length with the TGT, transfer guide tube, connected before treatment, because the channel lengths or the transfer guide tube distance measurements used to change with the passage of time. So it is advisable to, if you are not doing this daily basis or before the treatment, before every treatment, at least you should do this quarterly basis. And if your measurement is not, if your measurement is more than the required one or lesser than the required one, then you can use this information as well while doing your planning. And I will show you where you can use this information. So this is the ring applicator, and commissioning of ring applicator require special consideration because there is a snacking issues with the source wire while moving into the lumen of the ring applicator. So there's a discrepancy, and which can cause different possible paths in the applicator. So it is very important to commission the ring applicator in-house in every center so that we can know what is the offset we should use while doing the planning. Because if you will not be using this information in the planning, then there will be inaccuracies, and which can lead to the geometrical miss and inaccuracies, as we were talking about, that it will lead to the geometrical miss as well. So it is very important to commission the ring applicators. This is a paper which we published in 2010, a new approach to measure dual position inaccuracy in HDR ring applicators, quantification corrective QA. So we published this paper and we devised a unique method to know what is the offsets required while using the ring applicators. Here you can see in the first picture that there's a small jig, perspex jig, which we made ourselves, which is an innovation basically. And the ring applicator is placed into this jig, and there's a notch in the jig which stops the rotation of the ring inside the jig. And this is a simple shielding which we use actually to hold the ring applicator into the perspective. Here you can see there are 4 opaque markers inside that particular applicator, which we use to define the axis of the applicator. And we simply mark the film, Radipack films with the simple lines, and you can see the lines, and the perspective will be moving along this line while measuring different offsets measurements. In this picture, you can see after like this is the simulator picture actually. So after like this is the initial or reference data, and you can see each marker, X-ray marker can be, I mean, like the angle can be known by having this simulator picture. So this is a reference data actually, which will be compared with the measurement data. In the following picture, you can see so that after delivery of different offsets. So here you can see this is a control line. There is no offset data, which is the red one, and you can see the stacking effect is very large actually. It is going up till 5 millimeter. So if you will not do any offset, then your measurement can, I mean, the source position can be offset by 5 millimeter. Planned versus delivered positions. So by having the 1 millimeter offset, you can see the stacking have been reduced. And having the 2 millimeter, you can see it has been reduced further. But now all the offsets are in the positive direction, and it is around, on the average, it is around 1 or 1.5 millimeter. By increasing the offsets further, you can see the offsets have gone a little larger, and it is beyond 2 millimeter. So we found that the optimum offsets in this particular applicator is around 1 to 2 millimeter. And published data also vet this numbers, and you can see different papers which tells that usually for most of the applicators, for most of the ring applicators, the data is showing that it is 2 to 3 millimeter. So with that, I can move to the second part of this lecture, which is the treatment planning. So there are 2 parts as well in the treatment planning. One is with the tandem and ovoid, and the second is with the tandem and ring. So I will go through both of these plannings. So let me hook up my Eclipse workstation. I hope all of you can see the planning system. Another, can you confirm, please? Can you see my planning workstation?
Yes, sir, we can see.
Okay. So up till now, if you have any questions, we can go through this question first, and then we can move to the second part. Is there any question about this first part from the audience?
So let me unmute, so if anyone want to ask.
Okay.
Now participants can unmute themselves if they have to ask any question.
Hi sir, Assalamu alaikum.
Walaikum Assalam.
So I just want to ask about the comparison chart which you showed regarding the dead space and office area.
Okay.
So you measure by yourself and you have some nominal values from variance.
Can you
So
see
which
now?
one? Yes, sir, I can see.
Okay.
So which values you are using in your TPS, the measured one or the nominal one?
Nominal ones, because measure ones, it's not very accurate to measure. It's difficult actually to measure the accurate things until unless you have the difference. And if you have the difference, then you can always refer this differences with the manufacturer, that why we are getting such high differences. So for example, if you are measuring 0.3, for example, against 0.5, then of course, this is something we should be worried about. And we can always consult with the manufacturer that, is there anything which has been like stuck, or if there is anything which has been like pasted at the distal end of the applicator. So we can also investigate ourselves as well, that what is wrong with the distal part of the applicator, because most of the time it is a distal part which has the dead space. So why the thickness have been increased? So if you cannot investigate this, then you can always refer to the manufacturer that there is a problem with the component of this particular component, and please advise what should we do. Like in one of the practical example, I can tell you that we were measuring our transfer guide tubes, which were around 133 centimeter against, against 130 centimeter. It was 133 centimeter. Sorry, 130.3 centimeter. So 3 millimeter will be 3 millimeter higher. So we referred this to the manufacturer, and then we got the answer, and we fixed this in-house. That is a different story. So how did we fix that? But there was an advice from the manufacturer that you should make this out of commission and use a new transfer guide tube. Although we were able to fix this issue, and now our all transfer guide tubes are 130 centimeter when we connect this with applicators. Is this the answer of your question?
Yes, sir. Yes, sir. Thank you, sir.
Sir, we have a question from a participant in the chat box. Which applicator do you use? Do you have?
We have tandem and ovoid applicators, two tandem and ovoid applicators. One is CT compatible, CT and MR compatible, and other one is not compatible with the CT. We have ring applicator as well. We have a Mac applicator from the Acker and Ziegler, and these are the cylinder applicators, of course, cylinder applicators, shielded cylinder applicators. So there are around 5 applicators which we are mostly using for our routine patients, cervix and endometrium patients.
Okay, we have another question from a participant. Have you measured applicator attenuations in terms of HU or electron density for verification?
We have not mentioned this here, but when we do the CT, we can do this, during the treatment as well. If you are not making the part, if you are not making this as a part of your quarterly Q or annual QA, you can use this, or you can measure this while you're doing the planning. But it is not our practice, but it is recommended to like measure the HUs quarterly or annually as per task group report.
Thank you, sir. That's all from the chat box. If anyone else have to ask, they can unmute themselves, or we can continue further.
Okay, so let's move to the second part of the today's talk. So here you can see there are, you can see the name of the patient, which should be the confidential, but I don't have any means to hide this name. So, and I hope that it is confidential among ourselves. So you can see the plannings. These are an old patient, and I chose this patient due to some specific reasons, and I'll let you know what are the reasons to choose this patient for today's talk. So this is CS service patient 2B, and there were 3 fractions. 2 fractions were with the tandem and ovoid, and 3rd fraction was with tandem and ring. So that is one of the reason I chose this patient. So let's start with the blank patient. Let me remove this applicator so that we can start with from the beginning. So now we can start. Let's say this is the new patient, for example. We can go through the slice by slice, and let's see what we have. So that the red is the PTV, HRCTV, for example, and this is the sigmoid. And here you can see the rectum. This is the rectum and bladder, of course. So this is tandem, which is going in the intrauterine tube. This intrauterine tube. So how can we start our planning? So for example, let's focus on the intrauterine tube, which is tandem. So you can focus this with the viewing intersection plans. And now you can move your planes so that we can see the whole tandem. So for example, let's move this in that way. So by moving the transverse planes into the transfer plane, into the sagittal and coronal plane, you can focus this. Let me enlarge a little bit. So now it is more visible. So you can see now, if you scroll through from superior to the inferior, you see that my tandem is falling at the intersection of viewing planes. So that is how you can see the whole tandem. Now you can see there is little deviation, and we can move this plane as well, for example, like this. The applicator we are using in this patient is fixed geometry, tandem and ovoid. So now the whole applicator is visible in this plane. So now you can insert a solid applicator, tandem applicator. You can put the name, and you can use the ready-made applicator which is available within the library. So either use this applicators from the library, or you can contour your own applicators. This part will be doing in a moment. Let's leave this for now. So now you can mark your tandem, and you have to mark the physical tip of the applicator, because in the following in a few minutes I will let you know why should we mark this physical tip. You can change the contrast if you like to have the better visibility. So now you can mark physical starting from the physical tip. Up till here you are comfortable. I think that you can mark up till here, which is the os. Now if you want to move further, then what you can do, you can move the planes a little more. Let's go this. Let's go down and you see now it is visible. So you can continue your contouring. And you should mark beyond the os at least, because your channel length should be larger than your dual source position. So it is advised that you should mark, I can correct this as well. Otherwise you will get the errors while doing the while doing the calculation. So it is advised that you should mark your channel length higher than the dual source positions. So we're done with this. Now what we can do, we can mark the right ovoid. For example, let's focus on the right ovoid in all three planes, and you can rotate the viewing planes. So that it is visible in all three planes. So I think it's fine now. We can scroll this as well. So it is visible all along the planes. With that, we can insert new applicator, and the name of the applicator is right ovoid. You can mark contour with the physical tip of the ovoid. It is very well visible, so there is no need to move the viewing planes further. And now we can mark the third component of the applicator, which is the left ovoid. Let's scroll and see if there is a need to rotate the viewing plane. Now we are fine, I think. Okay, so now again we can insert the new applicator, which is the left ovoid. And we can mark this from the physical tip. Okay, so we have finished with this. Now there is also people have like talked about this, that we should mark the point A as well, although we are doing the city-based planning, but for the reference, because the volumes are, if you are not comfortable that if you cannot achieve what dosimetric isodoses you want to see, then at least you should cover the point A, ICRU point A doses as at least, so that if, which is classical actually, and which is, there's no wrong actually by doing with this, while following this ICRU protocol. So people have thought about this, that either while you are doing your city-based planning, even then you should mark your point A, so that you should at least deliver the dose to the point A. So what we can do for this, let me see if we can do this here, or otherwise we'll be doing this in the other session. I think because my user origin is not visible, because there are multiple plans which are approved, so I cannot freely do everything here. So I don't see my user origin here. So I will let you know I'll show you in the other plan. Let's skip this for now. I will complete this point in the following plan. Okay, so let's do this. Now what we can do, we can put the dead spaces, for example, for the tandem and ovoid. For this particular applicator, we can see here the channel length. If your channel length is not 130 centimeter, you can always put the numbers you have measured, for example, 130.2. Or you can increase by putting the first source position. So let me try. We have never used this actually. It says that it should be greater than 130 and less than 130. It should work. I don't know why it's not working, because it says that the values must be greater than 130 centimeter and less than or greater than 130, equal to 130 centimeter. I don't know. I'm not clear about this because we have never used it, because we always try to fix our transfer guide tubes. The length, total length of the transfer guide tube with the applicators should be 130 centimeter. Otherwise, we fix this. So let's keep this for now, 130 centimeter. Step size, we always follow 0.5. Some people use 0.3 as well. It depends on how much resolution you want to use. The first source position, that is the first source position from the tip of the applicator. So for this particular applicator, we have a dead space of 0.35, which is 3.5. I think there is something wrong with this because let me check. I don't know, because there are plans which are already delivered, because I have used this before and I have used 0.4, which is fine here, but why not 0.35? There's some anomaly, I don't know. Let's keep this 0.4 for now. And the last source position, that depends on the how much dual positions you want to place into your tandem. So for example, our tandem is, let me check, a rough estimate will be here. So it's around 5 centimeters. So what we can do, we can put 5.2 so that last source position should be delivered. So you can see here. So it has been, and here you can see the first source position. You see, first source position is away from the tip. So it is measuring from the dead space. So let me put a little bit. So that is a dead space, 0.35 millimeter, 0.35 millimeter. So, and that is because we have put this here, 0.4. It's 4 millimeter. Let me check. I think that is more visible in the next part. Let me check if I can do something in the next part. In the next planning, because I did this in the ring applicator. So let's do the same thing with the ovoid as well. So for the ovoid, again, my dead space is 0.3 and my size of the ovoid is 3 centimeter long. So we can put 3.2 so that the last position should be filled. Here you can see 6 positions. So 5 to 6 is the normal positions. The same with the left ovoid, 0.3, and you can put this 3.2. So now sources have been filled, dual sources have been filled. After that, you can put the dwell time into the like every component of the applicator. So for that, we can fill this times by using this dual control window. It's very easy. And again, classically, let me show you. Historically, because it is all, I mean, like the times are all standardized with the radium at the era of radium. So it is advised that you can put 15 seconds in the first one third of the tandem. For example, 15 seconds, 15 seconds, 15 seconds, and then 10 seconds, 10 seconds in the last two third. So 10 seconds, 10 seconds, 10 seconds, 10 seconds. And in the ovoid, 15 seconds to start with. After that, you can do your own optimization. 15 seconds, 15 seconds, 15 seconds. So it's all reference with the classical radium LDR times, which we used to see when we were doing the LDR. So that's there. Now you can close this window, you can calculate, and you see you came up with the standard plan. That's the standard plan you can use. Now you have to normalize this with the point A, which I have already marked, and I will show you this in the ring and tandem session. Let's normalize this to the point A, which is a reference point, point A. So that is a standard plan, which is based with the Manchester protocol. And now what you can do, now you can optimize your plan as per the HR's CTV, which is marked here with the name of PTV. So now you can enlarge this. Again, there's a limitation. So keeping in view the rectum and bladder doses, here you see the rectum and bladder. And with the help of oncologists, radiation oncologists, you can optimize as per their desire, that what they want to treat, how much dose they want to have to the rectum and bladder. After finishing this part, what you can do, you can go to the report, which will show you the dosimetric parameters. Here you can see the bladder dose and the rectum dose. And again, these are the based on the American Brachytherapy Society, ABS. So they, in the image guided brachytherapy, they want to use the dose to the 0.1 cc of the bladder and dose to the 2 cc of the bladder. Similarly, dose to the 1.1 cc of the rectum and dose to the 2 cc of the rectum. Rest of the dosimetric quality parameters I will show you in the next plan. So that is the planning for the tandem and ovoid, and the next plan is for the tandem and ring. So let me remove the applicators. So now we can start, and let me reset the geometry as well. Okay, let's leave this for now. We can do this like this. Okay, so let's see. Let's say that it's a fresh plan, and we are starting with the new plan. So let's do this. For example, if you want to adjust the contrast level. Okay, so we can start with this. Let's scroll through the plan and the target volume. So here you can see the HRCTV. So HRCTV is there, then sigmoid is there in the yellow. Then after that, you can see the rectum is here. And bladder should be there as well. Here you can see the bladder. So these are the structures we have or the oncologist has marked. So we can start the planning now. Again, as we did in the tandem and ovoids plan, that we should focus first with the tandem. So let's see where's the tandem. Here you can see the tandem. So let's move the transverse plane, cross-section planes to the, and let's enlarge this, for example. Okay. So now we can move this, we can move this, and we can move this as well. So let's rotate the planes so that we can see the whole tandem in all three planes. So now let's scroll in the transfer slice, and you see my cross-section planes is always in the center of the tandem. So vertical plane, you can see this plane. Okay, so if you want, you can move it a bit. Here as well. So now we are comfortable with that, and we can see the whole. Here you can see the rectal retractor. The oncologists use the rectal retractor, and these are the ovoids, and this is the tandem. So let's insert the new applicator, tandem. Okay, now control the tandem, or we can rotate it a bit more. Now it is more visible. Okay, so let's put off this and turn on contour session. So now we can, from the physical tip of the tandem, we can contour the tandem, passing the ring. There is no harm to contour larger distances. At least it should be bigger than or larger than the dual source channels. Okay, after that, what we can do, as I was telling you, that user origin should be put. If you want to put the point A, then easiest way would be to put your user origin at the OS level. So for example, this is your OS, and it should be visible here. So here you can see the OS level. So what will be the benefit that when you turn on the grid, for example, and let's make it 2 centimeter. So here you can see the 2 centimeter distance very easily, because our ICRU point A and point B is at the 2 centimeter from the OS and 2 centimeter laterally from the tandem. So now we can easily mark our point A, right point A, and right point, left point A. So I don't know if it is visible for you. Let me make it a little more darker so that you see. And this difference is basically due to the rotation of the different planes. Otherwise, it is exactly 2 centimeter from here, from the os, you see 2 centimeter, and laterally 2 centimeter from the tandem. So you can easily mark your points like this. Now let's move to the ring session. So let's now focus on the ring, and we can again, let's make the contrast a little better. Okay. Now we can focus, let's talk off the grid as well. Okay. So now let's focus on the ring part. So fortunately, I think, and what we have done this with this patient and with this ring applicator, we have inserted an X-ray marker. Let me show you the X-ray marker. Although it produces the artifacts, but for sometimes we use this X-ray markers just for the sake of surety that our distances are okay. So for example, let's now move our plane so that we can view this ring applicator in all 3 planes. So for example, there is a little bit here we can move. It is more visible now. And if we move from in the transfer plane, we can see that the planes are, I think it's almost there, and we can very these are very well visible. So these markers are 1 centimeter apart, and here you can see, let me enlarge this. Here you can see the tip of the ring applicator ring. Let's measure this distance just to verify. Our first source position is 0.35 from the lumen. So this is the lumen, and you can see it's 0.135, and the dead space, let me verify, the dead space of the ring is around 0.4. So 0.4 plus 3.5 millimeter makes 3.9. So here you can see the first X-ray marker is 3.9 millimeter from the tip of the applicator. So like this, we can verify distances. So now let's these numbers here. Step size is fine. This is fine. So first source position should be at dead space is 0.4, and channel length for the ring is 9 centimeter, for example. So let's put 9.2. So the last position should be drawn. So I did that for the tandem. Let me put the numbers for the tandem. So tandem is 0.4 and 6 centimeters the tandem length. So 6.2. So this is fine now. So let's now put the other channel, which is the ring. And for the ring, we can put 9.9 centimeter. So let's put 9.2, and the first source position is 0.4. The dead space is 0.4. And this is the dead space you can additionally put because of the stacking effect. So for example, 0.2. But let's remove this for now so that I can show you the actual dual sources into the channel. Let's leave this for now. Okay, now mark the channel first. So for example, from the physical tip, you can start from the physical tip. you are going at the center of the lumen. Again, you should mark the channel little more than the number of dwell positions you require. And for that, you can move a little bit down, for example, here, and you can mark. You can mark here as well. Okay, after that, you can put your, you can fill the positions. It's already filled. And what you can do, you can remove the last source position, I think. Let's see if you can remove this. For example, 8.6. Yeah, it's fine now. And what people do is that because you don't want positions at the rectum and bladder level, so anterior posterior, you don't want to have any position. So you can remove this from the channels, either from the control valve positions, for example. Here you can remove this if you don't want to see those positions to be filled with any dwell time. Otherwise, you can leave this as well. So for example, let's put the numbers as we did in case of the tandem and ovoid. So 15 seconds, for example, we can start with 15 seconds for the first or the upper third, 1/3 part, and 10 seconds for the lower 2/3 part, and 15 seconds for the ring. You can close this, you can calculate this. And here is a standard plan by having the normalization to the point A, any point. So this is a standard plan you can achieve very easily. So let me remove this. Let's calculate this, keep the points. Let's bring this down. So that's the standard plan. Now it depends on how you want to optimize. For example, dose rescaler. You can increase this, you can decrease this area. And now oncologist should be sitting with you while optimizing this or rescaling this. Let me do this. Okay, so it is more visible now. So sigmoid, rectum, and bladder. So these are the competition between all these three, and HRCTV on the other part. So now what we can do, we can see the yellow line, and you can see there is more actually here. Reduce this. Because it's symmetric, so we can increase something a little bit about here as well. You can reduce this. Okay, now in the report section, you can see all your dosimetric quality parameters. We amended this, you can see it's AQJ, brachy full AQJ. So we amended this TML file, and whoever is interested, I can teach him how to amend this file so that you can see all these parameters. So let's see. So you want to see HRCTV and all these dosimetric parameters. For example, D90, V90, V100, V150, V100, V200, and for the bladder we have put in 2 parameters, which is, so whatever you want to see in your report section, it's directly accessible here. Otherwise, you will have to go to the DVH, and from the DVH, you will need to sensitivity. You'll need to find out from here as well, from this window. So it is tedious actually to find this numbers from this window. So you'll have to see the range. You'll have to select the range as well. So I used to use this dosimetric window out of this report. Once you have configured your report correctly with the parameters you want to see, then it's always available with you. So these are numbers we used to see with the image guided brachytherapy. So I think that's it from my part. If you want to go with the volume based treatment planning, then you will have to optimize this with the by covering the volume. And in this case, of course, you cannot cover the whole volume, because the volume is larger and away from the tandem, at least the superior part. So in which case, oncologists used to advise that go with the point A. Otherwise, you will have, in this case, of course, you need the needles as well. If you want to push the dose laterally, then you cannot push the dose laterally until unless you put the needles in this area. So I think that's all from my side. So from the audience, I think it's 1 o'clock, 1 hour we have like taken from you. So with that, I would end and will ask the audience if they have any questions. Unada, can you unmute the audience?
Thank you, sir, for such an informative session. We have a question in the chat box from our participants. Do you do interstitial brachy with needles?
We have acquired the